morning, everyone. Today, I would like to share what is happening on the ground with IHRI in Southeast Asia, particularly in the region of Myanmar, Thailand, and Cambodia borders, and also how community-led responses are filling the critical gaps where systems fail. Oh, sorry. It's not moving here. But I just realized that it's moving. I just need to refer to this, I'm sorry. Must be me. Okay, sorry about this. Before I begin, here is a quick overview of what I'll be sharing today. I'll start with a brief introduction about IHRI, and I will set the context around IHRI in Southeast Asia, what the landscape looks like, and especially cross-border areas. And then we will look at what is happening right now on the ground, what communities are facing, and how current policies are affecting access to services. We will then move into the gaps and barriers. What prevents people from accessing harm reduction services, and including legal, structural, and funding barriers. From there, I will share best practices and integration opportunities, showing models that already work and how multiple services can be integrated for better outcomes. Next, we will talk about the importance of community leadership and what enabling environment is needed for effective and sustainable harm reduction. And finally, I will end with key recommendations followed by questions and answers. That's the flow. Let's begin. Southeast Asia Harm Reduction Association (IHRI) is a regional harm reduction network covering 8 countries in Southeast Asia. We are community-led, meaning people who use or inject drugs are not only our beneficiaries, they are leaders and decision makers. Our mandate and activities focuses on referral systems in cross-border areas, capacity building, policy advocacies, and amplifying community voices in regional dialogues. In Southeast Asia, we continue to face 3 major challenges that directly affect access to harm reduction services across the region. Let me start with the criminalizations. Across the region, punitive drug laws and police crackdowns pushes people away from services. So instead of receiving support, people fear arrest, harassment, or forced detention. This drives them underground, making HIV and overdose risks even higher. Program closures due to donors withdrawal, including USAID and others. Many harm reduction services rely on external fundings. When donors withdrawal, programs close, especially drop-in centers and outreach services. So these closures leave entire communities without proper, harm reduction aspects like basic, for example, needle syringe programs or overdose prevention. And the last one is a fragmented and poorly integrated harm reduction services. Even where services exist, they are siloed. HIV, mental health, or prevention, overdose preventions are rarely linked to each other. So people must navigate different systems of their own, and many fall through the cracks. So criminalization pushes people away, funding cuts eliminates the services, and fragmentation makes it hard to assess what from it. So this is why regional collaboration, coordination, and advocacy is essential to keep harm reductions and to ensure not to leave, and no one is left behind. In the border areas, people face particularly harsh environment. There are crackdowns targeting people who use drugs, sex workers, LGBTQIA+ individuals, and undocumented Myanmar refugees and migrants. So these crackdowns already push marginalized population further underground, making it unsafe to seek help. And second is mobility issues, lack of legal status and language barriers. Language barriers. So many migrants cannot navigate local health system, and even simple communication becomes barriers to care. That is, local clinics require documentation. So most of the local clinics require official documentations, which most of migrants do not have. So as a result, people refuse care for fear of arrest or deportations, although they need medical attention urgently. So this creates gaps in HIV, HCV, TB, and harm reduction services coverage. So these factors create a perfect storm, and vulnerable populations remain invisible, underserved, and at higher risk. So although there are few services available in the border area, we still like to highlight there is an urgent need for targeted, accessible, and safe health environments in border areas. When we look at harm reduction in the region, there are 4 key barriers that limit access and effectiveness. I will not go there again for punitive drug laws, as we already discussed in the earlier slides, and also no integration across HIV, HCV, and mental health programs. So let me highlight only for mandatory registrations. Some programs require individual registrations officially. So although we intended for monitoring purposes, but sometimes it leads to loss of confidentiality and discourages people from seeking care. For funding, globally only 4% of harm reduction needs is actually financed, but for Southeast Asia, we have only 2% of harm reduction needs is actually financed. So when funding is very limited, we cannot provide comprehensive or full package of harm reduction services, although we know that there is a needs is growing on the ground. So these barriers, laws, registrations, fragmentation, and funding caps creates very limited access for our vulnerable people to access harm reduction services. These barriers have very real consequences for communities in border areas. First, about 40% of Myanmar refugees and migrants lack access to HIV, HCV, TB, STI services. So, meaning a large portion of population remains untested and treated and highly vulnerable to infectious diseases. Second is that these clubs contribute to increased HIV vulnerability, higher overdose rates, and widespread of mental health diseases. So people who use drugs or sex workers and like marginalized populations are not only at high risk of physical health issues, they also have a significant psychological stress due to stigma, fear, or uncertainty. Third is peer networks operating without resources and without safety. Peers, educators, and communities are key players, to reach into the marginalized populations. Yet they lack funding, training, and protection. So this limits their ability to provide essential support, or like we even let them exposed to the social and legal risks. So to fix this, we need steady funding and proper or better systems to ensure safe and accessible care. IHRI's approach focuses on regional coordination, capacity building, advocacy, and youth leadership. So we translate community evidence to policy, so turning data to advocacy. For us, harm reduction is not only about public health, it is about people's dignity, agency, and human rights. So now I would like to share IHRI's emergency response to Ghana with support from Frontline Aid's Rapid Response Funding. Our goal is to rapidly restore harm reduction services where access has been interrupted. We recruited and trained. I will not go through very details, so we can discuss later on, just to save some time. So, this shows we are implementing in Myanmar, Thailand, and Cambodia border area. So this shows one key lesson from this project. One peers lead service reach people faster and lives are protected. With support from Open Society Foundations and partnership with Ghana, IHRI is implementing cross-border duplicable harm reduction referral system in against Myanmar, Thailand, and Cambodia borders. So we are mapping service gaps, setting up referral pathways with existing CSOs and clinics, and launching a peer-led drug early warning system to monitor new substances used in the region in real-time manner. So the idea is very simple for this project. Harm reduction should follow the person, not the passport. Integration opportunities, there are several opportunities to integrate harm reduction into existing public health systems. So integration means linking HIV services with overdose prevention, so mental health or legal support programs. So instead of creating separate services, we embed harm reduction into what already exists. So this reduces cost, increase sustainability, and makes services easier to access. The region already has successful models we can learn from. In Myanmar and Indonesia, peer-led outreach distribute harm reduction kits and provide overdose awareness and safer use education. And Vietnam runs mobile methadone with a basic mental health training, reaching to rural areas or how to access that area. And in Malaysia, integrated clinic models combining OST, HIV, TB, HCV, sexual health under one roof. And also we are also seeing drop-in centers in Thailand, Philippines, Myanmar, Malaysia, offering psychosocial and legal support. And importantly, we can see APS focused peer initiatives and also mental health integrations are emerging. So these are the examples shows like integration and peer leadership make a real difference. So community leadership is the heart of sustainable harm reduction. Peer co-design and implement services because they know what is effective and what is not. And we focus on fair pay and recognition and community data ownership. So meaning peers are not only delivering the services and also they are shaping the policy advocacy or policy change. So this shift is from participations to leadership is what makes harm reduction accessible and resilience. So for harm reduction to scale, we need political and policy change. First, we must replace punitive laws or policing, harsh policing with health-first approaches. Second, governments need to co-finance harm reduction through domestic funding and social contracting. Third would be remove mandatory registrations for some of the programs that discourages people from accessing services, and finally recognize of community-led organizations as a service provider. So without policy change, community efforts can go only so far. These are the main messages from today's presentations. Community-led harm reduction delivers reach and trust, and capacity building transform participations from participations into leadership, and integrations means continuity of care. Peer networks are essential partners in service delivery and policy change. Decision must be based on data, not ideology. And finally, governments must shift from punitive law or drug policies to a right-based health approaches. Regional collaboration makes all of this stronger. So please feel free to reach out to us, and we are always open for collaboration, exchange, cross learning or partnership. So we have a website and Facebook, and also we have a LinkedIn. Please follow us. And thank you so much for your kind attention. And we would like to invite some questions. And I would like to invite my colleagues to the stage as well. Thank you.